welcome to the pharmacology class, and today's topic is cholinergic antagonists. And cholinergic antagonists block the cholinergic receptors, and that will inhibit the uh, muscarinic receptors mostly, because most of the cholinergic drugs are most useful cholinergic drugs are muscarinic blockers, so they block the cholinereceptors. And there are also nicotinic blockers that will block the ganglionic junctions in sympathetic and parasympathetic nervous system. And the third group is neuromuscular blockers that block the nicotinic muscular receptors in the neuromuscular junction. So these are three groups of the drugs that we will discuss today. And the classification for the choline blockers includes the anti-muscarinic drugs. Thus, these are most useful, and the prototype drug here is atropine. Atropine is a poison, but also used as a drug, and the derivatives of the atropine are benztropine and cyclopentolate, and the ipratropium is a non-soluble derivative that is used for the treatment of the asthma. Other drugs include oxybutynin and scopolamine. Scopolamine is used for the treatment of the motion sickness, and diphenhydramine and desothironide are used for the treatment of other diseases. So we will get to every of these drugs later. So, like for example, tropicamide are mostly used in ophthalmology and other drugs. So these are most useful drugs, and we will mostly discuss these groups today because they block the muscarinic receptors selectively, and that blocks the parasympathetic effects. So the ganglionic blockers include mostly nicotine. Nicotine is a component of the cigarette smoke, and nowadays the transdermal patches with the nicotine are used in smoking cessation programs. And ganglionic blockers are non-selective. They inhibit the sympathetic and parasympathetic effects, and that is why the clinical application is very limited. And neuromuscular blockers mostly used in surgery, and mostly the prototype drug is succinylcholine, and other drugs like vecuronium are used mostly in our country. So cis-atracurium is actually the long-acting derivative of atracurium, and pancuronium and rocuronium are also long-acting drugs. So we start with the atropine. So from the top with the atropine. and atropine is a belladonna alkaloid and has a high affinity for muscarinic receptors. It prevents acetylcholine from binding into the receptor, and it acts on the central nervous system and on the periphery and on the peripheral nervous system. The atropine will the effect of the atropine will last for about 4 hours, uh, except for the when it is placed to the eye. The action can last for weeks, and for that reason the tropicamide, short-acting derivative of the atropine, is used in ophthalmology. That will act that will only the duration of action of that is about 1 or 2 hours. So because the atropine will lead to the uh, adverse effects that are not comfortable during several days, that is why nowadays atropine is not used in ophthalmology anymore. So the M cholinergic blockers will act on the parasympathetic nervous system and will block the muscarinic receptor on the postganglionic uh, synapse. So the postganglionic neuron that has a muscarinic receptor, and the acetylcholine is agonist of that receptor. So this is the site of the action of the muscarinic receptor. The atropine will uh, block all the cholinergic activity in the eye. That will lead to the dilation of the pupil, that is called mydriasis, and also cycloplegia, that is the unresponsiveness to the light. So, and for that reason, the uh, focus for the near vision is disrupted, and patient cannot see anymore. So also some patients can feel the some patients will in some patients it will lead to the increase in the intraocular pressure. uh, so that is why it's contraindicated for patients or the patients with the glaucoma that have a higher intraocular pressure, so the problems with the ocular pressure, then it's contraindicated. Also, atropine can act on the gastrointestinal tract, and it will reduce the activity of the tract, and uh, the derivative of the atropine, scopolamine, is mostly used for that indication. Uh, the uh, the the atropine and scopolamine are only used for the motion sickness. They are not used for the treating of the ulcer, peptic ulcer, because they don't reduce the hydrochloric acid production, and uh, for that purpose, benzapine, uh, selective M1 and muscarinic receptor antagonist, is used. uh, so benzapine is actually the drug of choice in the treatment for the blocking of the M muscarinic receptors in the GI. Also, atropine will act on the uh, urinary system. So, and if the patient feels the uh, hypomotility of the urinary bladder, the atropine can be used, especially in children with involuntary voiding of urine. And so also atropine will act on the cardiovascular system, and the it also acts on the muscarinic receptors that are actually on cardio or myocytes, and the heart will respond to the atropine depending on the dose. At low doses, it will uh, lead to the bradycardia, the decrease in the cardiac rate, and uh, in the high doses it will cause tachycardia. But usually the atropine is not used in the doses when it leads to the tachycardia, so that is why mostly it will lead to the bradycardia. And the bradycardia results from the blocking of the M1 subtype of the cholinergic receptors that are located on the inhibitory prejunctional neurons. So that uh, with the also the atropine blocks uh, the cutaneous the salivary glands uh, that are located uh, in the in the oral mucus, in the oral mucous membranes. The salivary glands are very sensitive, and as so as the sweat and lacrimal glands. So um, in high doses, atropine can lead to the over uh, overheating of the body because of the sweat is not produced and is not uh, uh, is not decreasing the body temperature by evaporation from the surface. So uh, the applications for the uh, the indications for the atropine and uh, other muscarinic blockers are based on the action on the muscarinic receptor. So the muscarinic receptor uh, will be blocked by the atropine or scopolamine or any other uh, M-choline blocker, and when the atropine will connect with the receptor, binds to the receptor, and then acetylcholine will not bind anymore, provided the concentration of the acetylcholine is less than the concentration of the atropine. That is usually the case. Uh, However, we can overcome this block by the increasing concentration of the acetylcholine in case of the, for example, case of the overdose, the uh, poisoning with the atropine or scopolamine, uh, and usually the uh, uh, anticholinesterases are used for that purpose. So these drugs will reversibly bind to the muscarinic receptor. And depending on the dose, the symptoms include bradycardia, that is low doses, and dryness of the mouth because of the inhibition of the salivary glands and inhibition of sweating. So this will increase the body temperature a little. Then in high doses, toxic doses will lead to the uh, rapid heart rate and the increase in the palpitation, that is pulsing of the veins on the extremities. Dryness of the mouth will be higher and pupils will dilate, that is the uh, action on the eye, and blurring vision is also indicate. I will start as if we uh, put atropine directly to the eye, because usually the atropine that is used systemically will not act on the eye. And in the toxic, in lethal doses will lead to the coma, hallucinations, and delirium, and the death. The therapeutic applications of the atropine include the ophthalmic mostly, and the mediatic and cycloplegic effects are used to measure the refractive errors without the interference of the accommodation of the eye. That is mostly used for the cases when the patient can uh, can interpret the results wrong. For example, in children or in the males that are admitted to the uh, surgery. So, uh, for example, a man that don't want to become a soldier, and then he will pretend he cannot see, but that is not the case. So then also the atropine is used as an antidote for cholinergic agonists. So for example, it's used of, of after the overdose of the organophosphate agents. For example, in the uh, organophosphate that are used in uh, to save the crops in farmery, uh, and in some mushrooms, uh, when children can be poisoned, or even adults can be poisoned with the poisonous mushrooms. So if you studied botany not very well and cannot identify the poisonous mushrooms, then actually you have to study pharmacology better so you can treat yourself after mushroom poisoning. So and uh, also the atropine is used as an antispasmodic agent to relax the GI and bladder. So if you feel uh, pain in the stomach, then that can help in case this pain is because of the spasm, and also as an anti-secretory agent to treat the uh, uh, to, to help during the during the surgery in the respiratory tracts. atropine is absorbed very well and metabolized by the liver uh, and excreted by the urine. Half-life is about 4 hours. The adverse effects include the dry mouth, blurred vision, sandy eyes, tachycardia, and constipation. So if you have sandy in your eyes, then uh, that is adverse effects of the atropine. So I hope sandy will not be in your eyes and will be near you, like in front of you. Don't you, Sandy?
Sure.
Thank you very much. So, so very useful name actually. I either in the botany nor in the pharmacology, so I'm glad that we have Sandy with
Thank you.
us. Thank you to you. So the nicotinic receptor blockers or ganglionic blockers act on the nicotinic receptor. So this is a nicotinic receptor that is on the neuromuscular junction, and the these drugs don't have a selectivity to the parasympathetic or sympathetic ganglia, because both sympathetic and parasympathetic, so both sympathetic, this one, and parasympathetic have nicotinic receptors, so the receptor is the same, and that is why there is no any selectivity. So the rocuronium, like this is a ganglionic blocker, um, will block both sympathetic and parasympathetic nervous system, and that is why they are not clinically useful, because sympathetic and parasympathetic are opposite to each other. When we block both, we have nothing, so there is no effect mostly. So uh, and so actually the ganglionic blockers will block all the autonomic nervous system. So and because the responses are very complex and very unpredictable, and that is why it's impossible uh, to achieve some uh, concrete uh, goals. Like you want to increase heart rate and it will decrease it will decrease it vice versa, so you will not get what you want, and that is why they are used very rarely as a therapeutically useful drugs. uh, However, they are used in the experimental pharmacology, and the experimental pharmacology is actually very far from the therapeutic application and the pharmacy, so that is why we will not discuss that much today. So, and nicotine is a component of the cigarette smoke and has many undesirable actions. So depending on the dose, nicotine will depolarize ganglia, and that will lead to the stimulation from the beginning, and then that will increase the blood pressure and the heart rate, because that will lead to the release of the adrenaline from the adrenal medulla, and also it increases the peristalsis and secretions. So uh, and then when you increase the dose even higher, the blood pressure will decrease, and activity of the GI and the urinary bladder will decrease. So uh, the so nicotine is mostly used for the smoking cessation, and uh, the in with the transdermal patches. So this is the only indication. So neuromuscular blocking agents uh, that block the cholinergic transmission between the uh, nerve endings and the neuromuscular end plate in the skeletal muscles. Uh, and they uh, uh, they also have the nicotinic receptor, but receptor is muscular type. And the neuromuscular blockers are divided to. So sorry, I'm when previously I told you that this is actually nicotinic receptor in ganglia. It's actually not in the ganglia. It's in the neuromuscular junction. So it acts the same, but actually this rocuronium and neuromuscular junction. So this is receptor is M type at the neuromuscular junction, not in the ganglia. So, but in the ganglia it is actually almost the same. But not rocuronium here, actually nicotine is here. So this is a neuromuscular junction receptor of the neuromuscular junction, and rocuronium, pancuronium, vicuronium, and other neuromuscular blockers will block this receptor. So and they are divided. So these drugs are divided to uh, uh, the depolarizing and non-depolarizing drugs. Uh, and they are mostly used in surgery to produce the muscle relaxation, and that will usually will allow to decrease the dose of the anesthetic. And anesthetics have many adverse effects that are undesirable, and that is why it's very useful to decrease their dose. And there are also central muscle relaxants, and they are used in the control of the spastic muscle tone. That includes diazepam, that is acts on GABA receptors, and also other drugs that are used mostly act on GABA receptors. So the first drug that was discovered for the blocking of the skeletal neuromuscular junction was curare. Curare, which was used by the native hunters of the Amazon in South America, yeah, is used to paralyze the animals. Uh, so they put that uh, poison to the arrows, and these arrows will hit the animal a little, and even a small wound will result in the paralysis of the muscles, and then the animal cannot move, and they uh, bind the animal and then bring it and to and then cook it. And because they cook the meat, then the curare is destroyed by the heat, and that is why it will not lead to the paralyze while eating the meat. And in modern era, the drug that is purified was tuberculin, and it introduced in clinics in during the Second World War, uh, and uh, that will help much uh, because it's during the surgery in the fields of the war that allowed to decrease the dose of the anesthetics, and that increase the safety of the anesthesia, because the less anesthetic is required to produce muscle relaxation. So the mechanism of action is uh, the same as for the uh, nicotine. So they bind with the nicotinic receptors and prevent the depolarization of the muscle. So this is anti-depolarizing agents. Uh, they are also competitive. So and the action can be overcome by increasing of the concentration of acetylcholine. For example, by administration of the neostigmine, that is an inhibitor of anticholinesterase. We discussed anticholinesterase last week. So at so the sensitivity of the muscles is different. Small muscles are uh, most susceptible and paralyzed first, like on the face and eye, and then the fingers, and after that limbs, neck, and trunk muscles are paralyzed. Uh, and at the last, the diaphragm is paralyzed, that lead to the breath inhibition and death. So they are only used in the surgery to relax the muscles, and they are injected intravenously because are not effective orally. Uh, so uh, the penetration through the membranes is very poor, and they are not metabolized. So all the drugs are excreted unchanged in the urine, and the vecuronium and tricuronium are deactivated in the liver, uh, and they are also excreted unchanged in the bile. Uh, so the difference between the drugs is in the onset of action and duration of action. So the depolarizing agents are a little bit different. Like for example, succinylcholine is a depolarizing neuromuscular agent, and it leads to the activation of the receptor and contraction of the muscle. But there is no relaxation, like the muscle is uh, always contracted, and then it will tire, and then it will not contract anymore. Uh, so the the succinylcholine is acting very fast, and that is why it's usually used for intubation of the patient before the induction of the anesthesia. Also injected intravenously. Uh, the duration of action is several minutes. Uh, so that is why for long acting, the long action is for the long action is infusion is required. Adverse effects include hyperthermia and also apnea. Apnea is because of the deficiency of the plasma cholinesterase. So this is actually because of paralysis of the diaphragm. Can lead to the death, but in very rare cases. So these are the main uh, 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 questions and uh, uh, outlines of the cholinergic locus. Thank you for attention, and what are your questions? No questions, then hold on, and then we will continue after the short break.